Let's dive right in. Before we can figure out what's broken, obviously, we need to know how the normal operation works, right? So let's trace the brilliant top-down flow of the HPO axis, the hypothalamic pituitary ovarian axis. The signal starts way up in the brain at the hypothalamus, travels down to the pituitary, drops further to stimulate the ovaries, and finally it hits its target, the uterus and outflow tract. When a patient comes in with primary amenorrhea, our job as clinical detectives is literally just to figure out exactly where on this vertical highway the traffic jam is happening. Here's our roadmap for today. We're going to cover the diagnostic threshold, look for our first clue, which is breast development, check anatomy when breasts are present, go on a hormone hunt when they're absent, do a rapid revision of our master algorithm, and finish up with a practice MCQ. Okay, starting off with Section 1, the diagnostic threshold. First things first, we have to define exactly when delayed puberty officially becomes a medical case of primary amenorrhea, and the diagnostic clock actually runs out differently depending on the patient's physical development. Primary amenorrhea is defined as no menses by age 13 if secondary sexual characteristics, specifically breasts, are absent. But if she does have breasts, well, we give the system a little bit more time, and that threshold gets pushed to age 15. The crucial takeaway here is understanding how the presence or absence of those secondary characteristics completely dictates the age limit we use. Now, the core diagnostic logic here is honestly fascinating because just finding where the flaw is instantly categorizes the whole condition for us. If the flaw is up high at level 1 or 2, so the brain, the FSH and LH are going to be low, giving us hypogonadotrophic hypogonadism. If the flaw is at level 3, the ovaries, the brain is going to be screaming louder to try and wake them up, right? That results in high FSH and LH, which is hypergonadotrophic hypogonadism. And finally, if the flaw is down at level 4 in the outflow tract, well, the hormones are totally normal, making it eugonadotrophic. This structure is basically your cheat code to the endocrine system. Moving right along to Section 2, the first clue, breasts. Let's see how this plays out in a clinical exam. This right here is the master split. Whenever you are faced with a primary amenorrhea question or an actual patient, you always branch your logic here first. Are breasts present? You might be wondering, why start there? Well, because breast development is your direct clinical evidence that the ovaries are functioning and actually producing estrogen. Think of it like this. If she has breasts, she has estrogen. If she doesn't, she's estrogen deficient. Asking this one simple question literally cuts your massive list of potential diagnoses right in half.
Which brings us to Section 3, breasts present, checking anatomy.
So what do we do if the answer is yes? If estrogen is normal, we know the hormonal engine is running perfectly. That means our detective work has to shift downward. We're now looking for an anatomical roadblock. And we do this by getting an ultrasound or doing a parectal exam. This creates our next big diagnostic branch. Either the uterus is present, meaning the blood is just trapped behind some sort of obstruction, or the uterus is entirely absent, which pushes us toward conditions like Mullerian agenesis or androgen insensitivity syndrome, commonly known as AIS. Distinguishing between Mullerian agenesis and AIS is an absolute classic exam favorite. Both of these patients have no uterus, but there is a massive genetic difference under the hood. Mullerian agenesis patients are genetically 46XX females. They have normal ovaries and normal female testosterone levels. AIS patients, on the other hand, are genetically 46XY males with testes that produce male-range testosterone. But here's the tricky part. Without a karyotype in your hand in the clinic, how do you tell them apart? The secret? You check the pubic hair. And this brings us to arguably the best, stickiest memory trick you will ever use for this topic. Hairy Mary has normal XX ovaries, but bald Alice hides XY testes. Let me break that down. The patient with Mullerian agenesis, or Hairy Mary, has completely normal androgen receptors, so she grows normal pubic hair. But the patient with AIS, bald Alice, lacks functional androgen receptors, so even though she has male-level testosterone, her body literally cannot respond to it. The result? Absolutely no pubic hair. Just remember, bald Alice, and I promise you'll never miss this diagnosis. Okay, let's rewind just a second on our algorithm. What if the ultrasound showed that the uterus was present? Well, that means we're dealing with an outflow tract obstruction, also known as cryptomenorrhea or hidden menses. And separating the two main causes is actually pretty easy. An imperforate hymen will bulge right at the vaginal opening. You'll see a distinct bluish bulge on a simple local exam. But a transverse vaginal septum, that's deeper. The local exam might look totally normal, but you'll feel an abdominal mass. For the septum, your absolute best next step is an MRI to map out the thickness and depth before anyone goes into surgery.
All right, we just successfully cracked the breast present cases. Let's start a whole new path in section 4, breasts absent, hormone hunt.
So, if our patient has no breast development, we instantly know she's estrogen deficient. Now it's time to order a serum FSH level. This is the exact gauge that tells us who to blame. If the FSH comes back high, it means the brain is shouting, but the ovaries are deaf. They're failing to respond. That's gonadal dysgenesis. But if the FSH is low, the ovaries are perfectly fine, and it's the brain that's asleep at the wheel, failing to send the signal down in the first place. Let's follow that high FSH branch first, where the ovaries are at fault. We essentially need to distinguish between Turner syndrome and Swyer syndrome here. In Turner syndrome, which is 45X, the key defining trait is short stature. Swyer syndrome is usually 46XY, and because their bone growth plates, the epiphyses, remain unfused, these patients will actually have normal to tall stature. To keep these straight, here is another essential memory hook for you. Short Tina turns on the heart and kidney alarms, but tall Sawyer hides a cancer risk. Why is this phrase absolutely crucial? Because finding a Y chromosome in a patient with dysgenetic gonads, like our tall Sawyer with Swyer syndrome, means a prophylactic gonadectomy is totally mandatory. You have to surgically remove those streak gonads because they carry a massive risk of turning malignant. Let's take a closer look at short Tina, or Turner syndrome. You really need to memorize these physical stigmata. Notice things like the webbed neck, the low posterior hairline, and the shield chest with widely spaced nipples. Internally, you're looking out for cardiac and renal defects, the most common being a bicuspid aortic valve and a horseshoe kidney, respectively. But here is a super important exam fact to remember. Despite all these physical challenges, intelligence in Turner syndrome is completely normal. Oh, and maternal age doesn't increase the risk of this condition at all. All right, now what if the FSH was low? That means the brain is at fault. We have two main suspects here, and you just need to remember this. The tall cowman can't smell his own cologne, while the short cousin is just a late bloomer. Constitutional delay is a diagnosis of exclusion. They're the late bloomer. Cowman patients, however, have a neuronal migration failure that takes out their olfactory placode, so they end up with anosmia, meaning they literally can't smell anything. Oh, and a really quick clinical pearl for you. Always rule out a cranial pharyngioma with a brain MRI, because it is the most common central nervous system tumor causing delayed puberty. We've unpacked a ton of brilliant clues today. Let's zoom out in Section 5, Master Algorithm, Rapid Revision. Let's rapidly reconstruct this entire algorithm top to bottom so it's locked in forever. This is your ultimate takeaway for clinical practice. What looks like a terrifying web of endocrine disorders is actually just 4 simple steps. Step 1, check your age thresholds, 13 without breasts, 15 with. Step 2, are the breasts present? Step 3, if yes, her estrogen is fine, so go grab an ultrasound to check the uterus. Step 4, if no, the estrogen is missing, so pull a serum FSH to see if the brain or the ovaries are the ones dropping the ball. It is simple, it's elegant, and it's foolproof. Finally, we arrive at Section 6, Final Case, Practice MCQ. Time to put on that detective hat one last time. Let's test everything we've learned with a real-world scenario. Here's our patient. A 15-year-old girl comes in with primary amenorrhea. She has normal breasts, completely absent pubic hair, a blind vaginal pouch, and an absent uterus. Think through that master algorithm we just built together. Where do these specific physical findings take you? Which path are you walking down right now? All right, let's break this case down step by step. Clue 1, her breasts are normal. That instantly rules out Turner syndrome because Turner lacks estrogen. Clue 2, the uterus is absent. Well, that completely rules out an imperforate hymen, where a uterus would be present engorged with blood. Clue 3, pubic hair is absent. This right here is our definitive tiebreaker. Malarian agenesis would have normal hair. But do you remember our memory trick? Absent hair plus absent uterus equals bald Alice. The diagnosis is androgen insensitivity syndrome. By just trusting the visual logic with this algorithm, you can confidently dissect literally any case that comes your way. So my final question to you is, now that you have the ultimate map to primary amenorrhea, which complex medical mystery are you going to decode next? Keep learning, and I'll catch you in the next explainer.